Ladies and gentlemen, it gives me the greatest pleasure to welcome you to RESPIRE 2024, the annual academic sessions organized by the Sri Lanka College of Pulmonologists. We have an interesting lineup of 6 different symposiums and 2 guest lectures for the day. We kindly request you all to keep your phones on silent mode at all times and enjoy today's proceedings. Let us now recommence the sessions for the second consecutive day with the first guest lecture on update on the management of pleural infection. The chairpersons for this session will be past president of SLCP, consultant respiratory physician Dr. Ravini Karunathilaka, and past president-elect of SLCP, consultant respiratory physician Dr. Niranjan Disanayaka.
Good morning, ladies and gentlemen. I think we had a splendid session yesterday, as well as a beautiful speakers' night. And this is the first session in the morning. And I'm indeed honored and privileged to invite Professor Gary Lee to the stage. He's well known, and I don't think he needs any introduction. And he's a friend, a colleague, and a dear mentor for the Sri Lanka College of Pulmonologists. And it's a real pleasure to have you here, Professor Lee. Thank you.
Good morning, and thank you for the opportunity to be here to talk about pleural infections. Pleural infection is a significant healthcare burden. It affects about 12,000 people each year in the United States, with a total inpatient care cost of about $370 million US. This systematic review of 125 papers across the world shows that the median hospital stay is around 19 days for these patients. When it comes to pleural infection, Hippocrates is always my hero. He wrote a lot of the landmark papers and used a lot of novel techniques at his time. And some of his sayings, like, if the empyema does not rupture, death follows, still stands in the sense that he emphasized the importance of drainage. He also, before the days of chest x-ray, stethoscope, or ultrasound, used to identify the pleural effusion by shaking the patient by the shoulders to listen for the sound of fluid in the pleural space. I tried it a couple of times, but I never worked. He also covered the thorax of the empyema patient in mud and identified the rib space that dry first as the best site for drainage of empyema. Pleural infection after 25 millennia remains a serious illness with rising incidence and mortality. But I want to emphasize that the patient profile has changed quite a lot. There is no doubt a rising incidence in pleural infection, especially in the elderly. So this is the hospital admission rate on the vertical column in the United States over about a 12-year period. And the higher in the vertical axis, the higher is the incidence. So you can see that as you get older, the chance of getting pleural infection is higher. But by far, the highest incidence is in those people who are age 65. And you can also see a very sharp increase in the incidence in the age group over 40 and over 65. This review of 134 papers shows that most of these patients has got significant comorbidity. About 3 out of 4 patients has got significant comorbidities, be it cardiac, respiratory, or cancer. We did a paper on the pleural infection patterns in Western Australia, where we have a population of about 2.5 million people, but we have a statewide laboratory system that captures 95% of all the positive pleural fluid culture tests. So over a 6-year period, we have 600 patients and almost 900 bacterial isolates. We also confirmed that comorbidity is common and present in about 2/3 of the patients, cancer being the most prevalent comorbidity. But we also found something interesting in that hospital-acquired pleural infection now outnumbers community cases by a ratio of 2 to 1. And half of these hospital-acquired cases are iatrogenic, especially post-operative cases. So pleural infection patients in the year 2024 are often elderly. They have significant comorbidity or may already be in hospital for another reason. And management therefore need to suit these target populations. And all-cause mortality is very high following pleural infection. So all-cause mortality for community or hospital-acquired infection while as an inpatient is about 15% in our cohort. But as you can see, as time goes on, by 12 months, 1 in 3 people with community-acquired empyema and about 1 in 2 people with hospital-acquired empyema will no longer be alive. So most of these patients, as you can see, die in the subsequent months after hospital discharge. It's not directly related to pleural infection. In the latest British Thoracic Society guidelines, it mentions about pleural infection and suggests that you should use the RESPIRE score to predict clinical outcome. This is a slightly controversial point. There's no harm in doing a RESPIRE score. It is a validated prognostic guide of all-cause mortality. So what does RESPIRE stands for? R stands for renal impairment. If you've got renal impairment, if you're older in age, so if you ever want to have an empyema, do it before you're 50 years old because otherwise the mortality increases, and certainly try to do it before you're 70 years old where the risk increases significantly. If empyema is non-purulent, it's actually got a higher risk of poorer outcome. Hospital-acquired cases and also patients with low albumin level also have poorer outcome. And you can see that the more points you scored on the RESPIRE scale, the more likely you are going to die within 3 months. But the important point to point out is that the RESPIRE score predicts all-cause mortality, not mortality specific to pleural infection. So my friend Nick Maskell used to call the RESPIRE score the crumbling score because what it means is that if you're old, you're in hospital already for some other reason, you got other end organ failure, and you have low in albumin, which usually means you have been sick for quite a while, then you're more likely to die. So pleural infection is a marker of frailty, and patients die from their comorbidity, but not so much from their sepsis. And so treatment like surgery is unlikely to reduce mortality significantly. So what happens to these patients? This is a very interesting study from Scandinavia where they always have very good databases, which makes us envious. So this study follows patients with pleural infection onwards for up to 15 years. And this is the survival curve. And these are the patients who have pleural infection. And these are the patients who are the age and sex match control in the general population who did not have a pleural infection. So you can see, once you had a pleural infection, you're more likely to die for the rest of your life compared with the general population. And the most common differences in the mortality is death from cancer, which is 2.5 times higher. The cornerstones of treatment for pleural infection has not changed over decades, which is to evacuate the infected pleural fluid and also to eradicate the infection. To evacuate the infected fluid, we need to use either chest tube, fibrinolytics, or surgery, or combination of the above. If you look at the large randomized trials, such as the multicenter intrapleural sepsis trial 1 and 2, most patients in the control group, which is the ones treated with chest tube and antibiotics, has a successful rate of treatment around 70 or 80%. So really, any additional treatment such as surgery or intrapleural therapy is really there to speed up recovery rather than to save lives. Around the world, surgical drainage is used very differently. It can be used in some centers as soon as possible or as an absolute last resort. And even within Australia, we see the two extreme ends of these practices. So the data is very limited on using surgery as the first line. There's been 2 randomized trials in adult empyema, both of them relatively small. On the left-hand side is the study of 19 patients in the United States. On the right-hand side, 70 patients from Turkey. And they are randomized to surgery versus chest tube alone or chest tube with streptokinase. Both studies found no difference in mortality, no difference in healthcare cost. Both studies shows that you will get out of hospital slightly sooner if you have surgery, and that was the only benefit identified. So what if infection persists despite optimal antibiotics and chest tube drainage? You might well all have heard of the MIS2 study, which used the combination of intrapleural tissue plasminogen activator to lyse the adhesions and use donase or DNAase to lower the viscosity of the pleural pus. Together, they seem to improve pleural fluid drainage, and in the randomized trial, these patients who receive both TPA plus DNAase has a significant reduction of the pleural effusion size on the chest X-ray, and less than 6% end up requiring surgery, so 94% are cured without surgery, and the length of stay was 7 days shorter than the control groups. But you need to realize that less than 50 patients actually received TPA and DNAase in the MIS2 trial because it was a 4-arm trial. So a few years ago, we started the first question, does the TPA and DNAase work in real life, and was it safe? So this is still to date the largest TPA DNA series of 107 patients. These are patients who are quite sick or have pleural infection, receive antibiotics and chest tube drainage for at least 24 hours and not improving. And in many centers, they would have been sent to surgery. Most of these patients has got at least one major comorbidities like cancer or renal failure. 46% has got frank pus and 87% has got loculated effusion. So we use at that time the regime that we use for MIS2. So this is what we usually do. Altiplase 10 milligram intrapleurally through the tube, clamp for 45 to 60 minutes, open for free drainage for 45 minutes, and then put in DNAase, clamp the tube for 45 minutes, open to free drainage for 45 minutes, and repeat the same cycle again second time in the day. And we usually have daily assessment with chest X-ray and blood inflammatory markers, and we usually use no more than 6 doses, but you can use less if the patient has already responded. With that, we have a 93% success rate in those 100-odd patients we treated in the open label study. They survived the infection, did not require surgery, and was discharged alive. What we see is that the pleural fluid drainage was a median of 250 mils before TPA and DNAase, and with TPA and DNAase, by 24 hours, it improved to 1.3 liters, and after 6 doses, it was 2.5 liters. And there was a corresponding reduction in the pleural opacity on the chest X-ray from about 35%, like this chest X-ray, to about 14%, like this chest X-ray. And the CRP, if taken at 100% at baseline, will drop by 50% by day 5. We've also subsequently published the only long-term safety paper on TPA and DNAase, which follows 62 patients who has pleural infection and treated with TPA and DNAase for at least 12 months before. None of these patients has recurrence of their pleural infection. All of them returned to previous employment status. All of them said they would be happy to have TPA and DNAase again if they have another need. And in the objective testing, it shows that there was no significant residual pleural thickening on X-ray, quality of life scores, and lung functions were satisfactory. This is another large series from the United States that collates data from 24 centers, 1,800 patients. They don't actually have a definition for bleeding. It is the clinician's decision whether the patient has bled. And they found that the bleeding risk is about 4%, which is very similar to our open label study. And the risk factors are anticoagulation, renal failure, and low platelets. The most important thing is don't forget that these patients, if they've gone for surgery, was also more likely to have bled and require blood transfusions. And the most important thing when you give fibrinolytics is don't panic when you see a lot of red fluid that comes out the next morning in the bucket. Intrapleural TPA consistently and potently stimulates a large volume of hemorrhagic exudative pleural fluid. It can occasionally be associated with a decrease in hemoglobin, requiring a blood transfusion, but stops when the TPA stops. Intrapleural fibrinolytics rarely causes major hemodynamic compromise type of bleeding like a GI bleed. If that happens, it's usually because the chest drain has lacerated the intercostal vessels and the fibrinolytics has exacerbated that. In the original MIS2 study, the doses used was 10 milligram TPA and 5 milligram DNAs, and it was an empirical number that we pick out from thin air. There has never been a phase 1 dose-finding study for TPA intrapleurally, and TPA accounts for most of the cost of this combination and always raises concerns of bleeding in clinicians. So we started a journey of dose de-escalation to find the lowest effective dose. And dose de-escalation is commonly used as a technique for reducing doses of drugs, especially in the elderly, but we're using it to actually find the optimal dose of TPA. We've also done a survey and find that around the world, different doses of TPA administration and dosing regime are being used, and the range of TPA doses ranges from 1 to 10 milligram. Most of the respondents said that they will adopt a dose, a starting dose, where we will treat at least 80% of the patients successfully. This is an interesting study about empyema in horses, and the vets has already been using TPA for horses. And in the study of 25 cases of horse empyema, the median dose of TPA that they used in total was 3.75 milligram. So using the MIS2 regime of 60 milligrams in humans is likely to be a gross overdosing of our patients. So we started the Altiplace dose assessment for pleural infection therapy, or ADEPT series, to find the lowest effective dose. So we lowered the dose to 5 milligram, and we find that 93% of patients were still successfully treated. So I think in a lot of the UK centers that has been adopted. And then we dropped the dose to 2.5 milligram, and we still find that about 90% of people are successfully treated. And so we are on the journey at the moment of using 1 milligram of TPA, and at the last count, at about 80 patients, we still having a very high success rate. And I must emphasize this is the starting dose of TPA that we use. It doesn't mean that you can't increase the dose. But the rationale is that we don't give 500 milligram of furosemide to our patient on day 1. We start with low, and then if they don't respond, we move up. And that's how we would advocate for TPA as well. Fibrinolytics versus surgery. In the latest British Thoracic Society guidelines, it has a slightly surprising recommendation to say that if the patient is a suitable candidate, then you should refer for surgery first up. This is not evidence-based, and despite the fact that it is advocated in this guideline. But at the same time, the European Respiratory Society published their pleural infection guidelines, and they say that most task force members would initiate IET, which is the abbreviation for intrapleural enzyme therapy, which is TPA and DNAs, within 48 hours of standard care as a potentially surgery-sparing modality if they have ongoing evidence of sepsis. In the absence of head-to-head superiority data, a surgical referral is usually also started in parallel to starting the TPA and DNAs, which means that if the TPA and DNAs doesn't work, you go to surgery, which seems to make a lot more sense. So there has been 2 pilot feasibility studies comparing TPA and DNAs versus surgery recently published. On your left-hand side is the single-center Seattle study. On the right-hand side is the multi-center UK study. Both of them have only 20-something patients on the left-hand side, and has 60 patients randomized to 3 groups, surgery, TPA, DNAs, or neither in the right-hand side. In the Seattle study, there was no difference in mortality, no difference in hospital stay, and they find that it was actually very difficult to do a study like this because the surgeon disagreed and took quite a few of the patients out of the study because they think that the patients are sick enough to need surgery and should not be randomized. And the median wait, even in this trial for surgery, was 3 days. In the UK study, the mortality, there was a significant difference in that the VATS group patients actually died more than the TPA and DNase patients, although most of them not related to pleural infection. There's only one patient who died directly related to treatment, and that was from post-operative complications. The hospital stay did not show us a hint of difference, and the protocol feasibility was also shows that the protocol cannot be delivered. They don't think that the patients who were randomized to neither group actually adhere to those groups, and 26 out of 60 patients deviated from the assigned treatment. An interesting fact is that 50% of people, the 20 patients randomized to the surgical group, 10 of them were not operated on. Then the most common reason was actually because they got better while they were waiting for surgery. And the median wait for surgery was 3 days. So if you combine all these data, you can see that most people actually got better with intrapleural therapy. And the median wait, even in trials, be it in UK or US, sorry, it should be US, is 3 days. So 3 days is what we need to complete the intrapleural treatment. So there's really no reason not to try intrapleural therapy while you wait for surgery and use surgery as a last resort. And there is a third randomized trial ongoing in Denmark, and this is not a pilot study, but a full-blown study, and the primary endpoint is hospital length of stay. Perhaps the most ignored part of treatment for pleural infection is actually broad-spectrum antibiotics. We need to know the bacteriology of your local empyema incidences to guide antibiotics, because we know that bacterial causes for empyema differs around the world. And the antibiotics you use needs to reach the pleura. Bacteriology of pleural infection is complex. 60% of pleural infections are culture negative, so we don't really know the organisms. And we know that the bacteriology of pneumonia and that of pleural infections are very different. So community-acquired pneumonia, these are the common organisms, as you know. Community-acquired pleural infection, the most common organism is Strep millerite, and you almost never see Strep millerite pneumonia. Anaerobes, Staph aureus, etc. So the only common organism between the two sides is pneumococci. And hospital-acquired cases has very different bacteriology from community-acquired cases. This is Western Australian data. And you can see in community-acquired cases, Streptococcus viridans or Strep millerite are the most common. But in the hospital-acquired cases, Staphylococcus aureus, Enterobacter, etc. are much more common. You can increase the bacterial capture rate if you put the pleural fluid into blood culture bottles, and it has been shown in many studies, more than just these two that I have listed in here, that you can increase the yield by about 50% if you put the pleural fluid into blood culture bottles. This is because a lot of the anaerobes will die if you put them in open air in the sterile containers. And therefore, that's why the anaerobic vial of the blood culture bottles captures most of the additional bacteria. And we have done the study to compare whether you use 2 mils, 5 mils, or 10 mils into the blood culture bottles, and they did not differ. So even if you got a very loculated pleural infection and you only got a very small number of mils of pleural fluid, do put them in the pleural fluid blood culture bottles. Another interesting question to ask is, are we looking in the wrong places for bacteria for pleural infection? So we often tap the pleural fluid, and we know that that has notoriously a low yield. So are we looking at the wrong places? So if you imagine yourself or the person sitting next to you and give him or her a name, imagine he is a Staph aureus or E. coli, where in the pleural cavity would you think that the bacteria actually wants to live? Would they want to live on dry land near to the blood supply and the nutrients, or would they actually like to live in the pus in between or the white cells, etc.? So to try to answer that question, we took exudative pleural effusions that are not infected, so most of them are malignant effusions, and we incubated them with Strep pneumonia strains that we collected from patients who had empyema or blood septicemia. And we used 26 different strains of pneumococci, and they all proliferated very rapidly in all the 11 samples. So this is the amount of pneumococci we put in at the starting dose into the fluid, and this is a log scale of the amount of bacteria. And by 24 hours time, we have an average of 4,000-fold increase in the bacteria after 24 hours. In fact, the pleural fluid offers a better growth medium than the commercial culture media our laboratory used for pneumococci. So proliferation was also independent whether you remove the cellular content by centrifuge beforehand. So we do know that pleural fluid is a potent growth medium, and so it justified aggressive evacuation of fluid. And this is an interesting study from the Oxford group, which they do ultrasound-guided pleural biopsy at the same time when they put in chest tube in people with suspected pleural infection. And this is the bacterial yield. Blood culture at that time, 10%, pleural fluid, 20%, but pleural biopsy give you almost a 50% chance of capturing a bacteria, despite the fact that 3 out of 4 patients were already on antibiotics at that time. It shows you two things. The biopsy might still be worthwhile even if the patient is on antibiotics, and antibiotics regime we use are not that good for eradicating pleural infections. The antibiotics you use has to get into the pleural space, and we don't know that in most cases. The Australian guidelines suggest piperacillin and tazobactam, which is tarsosin, as the first-line antibiotics for pleural infection. The British Thoracic Society guidelines say that you should use beta-lactams and penicillins combined with beta-lactamase inhibitors. But the pharmacokinetics of beta-lactams is very poorly studied within the pleural space. This is all the adult papers on the top, and these are some pediatric papers that has looked at beta-lactam antibiotics pharmacokinetics in the pleural space. And you can see only one paper has more than 5 patients in adults. And you can see most of the papers only use 1 or 2 time points for pharmacokinetic studies. So even in my very poor pharmacology knowledge, I would say that that is not adequate. So Natalia Popowitz, who is a very talented PhD student, actually developed her own assay to measure piperacillin and tazobactam in patients with pleural infections. And in the first few patients, we actually see that this is after you give IV antibiotics, and then, of course, you see a spike in the plasma level of the antibiotics. But there was no such spike in the pleural fluid after you injected intravenously. And each of these lines represent a patient. And you see that most, but not all the patients, the antibiotics reach the MIC level, but the recommended level of tissue penetration of antibiotics to the site of infection is usually 4 times the MIC, and only 1 out of the 6 patients we studied actually reached that level. So there's, and the same findings for tazobactam. So there's a lot we need to know about pleural antibiotics. So how do I manage pleural infection in the year 2024? This is a 42-year-old lawyer. He has some young kids at home who all suffer from respiratory tract infection, and then he fell ill, and he would present to the emergency department febrile with left-sided chest pain. And you can see on the X-ray and CT scans, he's got multiloculated collection, basal, lateral, and apical. So the first step is always the same: antibiotics, whatever is the most appropriate in your practice region. And in our case, tarsosin was started, and chest tube drainage. So we put in an 18 French gauge ultrasound guided into the lowest locule, and has got some clearance. But as you can see that he's still got a lateral collection and an apical collection. If the infection, be it the fever and the inflammatory markers, which is the white cell count and CRP, does not settle despite optimal antibiotics and drainage, this is the time we start intrapleural TPA and DNase. So after 2 doses, you can see the lateral collections completely cleared, but he still have the apical collection up here. So if the residue loculation still persists, then sometimes you need more than one drain because it's too far away. So this is what we did. We put in a second drain, ultrasound-guided 12 French gauge at the bedside, and then we just put in 2 doses of TPA and DNAs, and you can see it overnight is completely cleared. So the patient was admitted on March 12, and we only saw him on the morning of March 13, and by March 17, we have cleared all the collections. The CRP responded correspondingly, and the patient went back to work the next day. Surgery in our center is now rarely needed for pleural infection, only in the small number of people where they have contraindication to TPA and DNAs in probably less than 5% of cases where they failed. If you're going to remember just one point of my talk, this next couple of slides is the most important point. Patients around the world are often sent to surgery unnecessarily because of incomplete clearance of pleural opacity on chest X-ray. This is a study from South Africa from Andreas Diacon that looks at what happens to the chest X-ray after pleural infection. So in Cape Town, his patients are very sick. On average, they have about 55 to 60% of the hemithorax covered by pleural opacity on chest X-ray. By discharge, 25%, by 3 months, 10%, and by 6 months, 5%. So the pleural opacity will go away once you adequately treated the patient, and the FVC responded correspondingly. I want you to think about pleural infection like lung infection or pneumonia, that residual changes will settle with time, provided the infection is controlled. You see this chest X-ray is a 29-year-old dentist who came under my care. As you can see, he did not have pleural infection. He just got a right upper lobe pneumonia. He was quite sick, but after 3 days of IV antibiotics, his fever and CRP was significantly improved. But I repeated the X-ray at day 3, and there was absolutely no change. So at that point, can I ask you what you would do? How many of you, hands up, would send him to lobectomy for the right upper lobe because it is not improved on the X-ray? No one. And I'm sure all of you will reassure him that the chest X-ray changes will settle with time, which is what I did. And then a month later, that's his chest X-ray. It would have been a crime to have sent this patient to lobectomy. But this crime is being committed for pleural infection every day around the world. This is an 18-year-old who has a very unfortunate ruptured appendix, was very septic in ICU for quite a bit of time, and has a pleural infection. And you can see there's been 2 chest drains. But by the time I saw her, her abdominal sepsis is also settled, and her fever and CRP is all settled. Our thoracic surgeon was very keen to take her to theater. Gary, come on, this is an 18-year-old, and he's got all this chest X-ray, nasty looking, got to clear it out. I said, there's no need. I have a perfect working relationship with my thoracic surgeon in my hospital. They do what I tell them to do. So I said, there's no need. I'll take full responsibility. And I took all the chest drains out, and I sent the patient home. Applying the same principle, reassuring her that the chest X-ray changes will settle with time. Of course, we watch her very closely. This is the discharge X-ray. This is 1 week, this is 2 weeks, and by 3 weeks, it's entirely normal. So treat the patient, don't treat the chest X-ray. There is a joke that my fellows knows. Gary would say, treat the patient, not the X-ray, and above all, treat the CRP. I want to finish by this fun slide. Sir William Osler, father of modern medicine, at his 100th anniversary of his death, we were asked to write part of his tribute in the postgraduate medical journal in a review series. And as many of you know, that he died from pleural infection or empyema. At which time he said empyema needs a surgeon and 3 inches of cold steel instead of the fool of a chest physician. So he underwent surgery, and most of the literature and most of the talks you have been to will tell you that he died from his empyema. But when we read the review article and looked through all the historic papers, I changed the history of pleural infection by this finding. We find that Sir William Osler underwent rib resection and surgical drainage, but he didn't die from the pleural infection, strictly speaking. He died at day 5 post-op from massive pleural hemorrhage. In the morning ward round, he was reported to be well, but by lunchtime, he has a sudden massive hemorrhage and was beyond resuscitation. It was not clear on post-mortem whether he died from the pleural bleeding site or lung bleeding site from the surgery. So strictly speaking, empyema did not kill Sir Osler, the surgeon in Oxford did. So in 2024, he would have come to us and he would have been treated with TPA and DNAs with a 90-something% success rate, likely not require surgery and would have survived the empyema. I'm going to thank my hardworking clinical and laboratory group for generating a lot of the data that you have just seen. And if you're interested in following us, we are on Twitter when we do pleural teachings on that as well. If you're interested in pleural research, etc., come and email us. Thank you.
So thank you, Professor Gary. That was very, very interesting talk. Now the forum is open for discussion.
Thank you, Professor Lee, for that excellent talk. My question is about the timing of the TPA DNAs. I know in the when you were describing the case, you explained that you started within. You explained that you started when the drainage stopped, but is there any change? For an example, what I want to know is, do you think there is a difference in starting at the time that we put the drain for an empyema, or waiting until when there is no fluid coming out to start?
Yep.
Yes.
So I think that's a very good question. Traditionally, people tend to wait for a couple of days before they start all these treatment. But really, if it doesn't come out in the first few hours, the chance of it coming out is very zero, is close to zero. So a lot of my American colleagues nowadays would start it even on the same day, a few hours after the chest drain is inserted. I haven't gone to that extreme. I usually start the next morning.
My question is about the duration of antibiotic for the empyema, optimal duration. And also, we don't have the DNAs here, so the altiplase alone, how much the success rate, or is there any studies about that?
Yeah, I'll answer the second question first. The question about DNAs is important because the study on streptokinase alone shows no difference. The four-arm study in MIS2 shows that TPA by itself also has a slight benefit, but really not reach statistical significance. So the general guidelines suggest that using fibrinolytics by itself does not make any difference. But of course, when you're desperate and you don't have anything else, then sometimes that can be tried. But I need to make a very important emphasis is that all fibrinolytics, where streptokinase, urokinase, or TPA, generates a lot of fluid. And the most important thing is not to be fooled by the fact that you give the TPA and the next morning you see a lot more fluid and you think you're doing a good job. You're not, until you check with ultrasound or X-ray whether the collection has actually reduced, whether the CRP and the white cell count and the fever has improved. So don't get mistaken, because chest physician has been for a long time before MIS1 get fooled because they saw a lot more fluid the next day and think that it is working, so let's carry on with it. It's not working if the white cell counts and the CRP and the X-ray or ultrasound is not improving. Now, the question about DNAs is beyond, it needs to be sorted locally. I think, are you going to be the next president? Yes, so this guy is what you need to help to sort this problem. Everywhere 10 years ago, 12 years ago, when we started talking about this, in Hong Kong, in Singapore, in Malaysia, they say, we don't have CF patients, we don't have parmesan, we don't have DNAs, this is too difficult. And then one enthusiastic hospital in Hong Kong find a way to start importing DNAs and find that it was marvelous. And they start doing that. And I gave the grand round in Hong Kong University and say, The Northern Hospital, which is a very small peripheral hospital in Hong Kong, is already doing it with good effect. And the Hong Kong professors suddenly all panic. How come the Hong Kong academic centers are not doing that? And they just instructed all their consultants to go and find a way to do it. And of course, as soon as they try hard, they find a way. And I told Singapore that Hong Kong is doing it, and Singapore said, how can Hong Kong be doing it and Singapore not doing it? And then I also talked in the APSR lectures on pleural infection, and I put the APSR president on the stand and say, why is Malaysia not being able to do that? And the Malaysian president needs to do something about it. And then they find a way in Malaysia, because they find that in the university teaching hospital, the rules of importing unlicensed drugs is easier. And so they started doing that in the teaching hospitals in Kuala Lumpur, and then it becomes a common thing. So I'm sure if you try hard enough, and Naranjan will find a way to find you some DNAs, because the DNAs is only a fraction of the cost compared with the TPA. So cost is not such an issue. It is just a way to get the drugs. Yeah.
Morning,
Sorry,
Gary.
so he will not invite me to come and talk about pleural infection.
Thank you, Professor Gary. It was a wonderful lecture, and I'm sure that my thoracic surgeon would be very, very upset. I'm from India, that he's going to lose some of the job from the next next opportunity onwards. But my question is that, you know, in this part of the world, I think a lot of people here would also agree that when we get an empyema, tuberculosis also is associated with it, and then we get into a trouble. So what would be your recommendation? Because a lot of us do feel that it leads to development of actually air leak also along with it, if you start using the two therapies together.
Yeah, so the first thing is that thoracic surgeons that I know of, especially in the public system, never get upset if you can get rid of all the empyema, so they can go home earlier and they don't have to deal with the so-called dirty cases. They rather do the clean things. I think it is very important that you separate TB pleural infections from bacterial pleural infections. So for TB pleural effusions, I presume you mean the majority of cases which are lymphocytic and they're not purulent. And those pleural effusions will get better once you started them with TB treatment. They don't really need to be drained even if the patient is not short of breath. And if the patient has got recurrent TB pleural effusions, then I usually treat them with steroid rather than keep draining them. And so TP and DNAs probably is not necessary for those kind of cases. But of course, that I mean the TB, the type 4 hypersensitivity TB pleural effusions. I don't mean the TB empyema, which is the TB with pus and often separate and often secondary infected with Staph aureus. Those ones, then you can have an argument of treating them with TPA and DNAs.
Yeah, thank you very much for very interesting lecture. I think in our practice, because of the limitation in the thoracic surgical services, we actually are almost nearly 100% managed by the physician, by as what you said, the antibiotics as well as, and our problem is actually delayed referral to us. We get patients with a really late cases, as you said, intercostal tube was not inserted, just giving the antibiotic, coming the highly complicated, septated, the empyemas and pleural effusion. So we do practice the antibiotics, and then we do the medical thoracoscopy because of, and we do not have services of a TPA because of the, it's not available in our regular, we use a streptokinase, and with the saline, with combined with that, because DNAs and TPAs are not available with us, only the cardiology available, and we can make use of, as you said, with the DNAs available. So we do more medical thoracoscopies with the complicated, septated, the empyemas and the pleural infection. And the early cases exactly follow the same what you said, and we are following that, and I think that we see a lot of pleural infections,
Yeah.
I think.
I think that those are very valid points. The most important thing we actually want to do in the next 10 years is to stop pleural infection from forming in the first place. And we've recently completed a multi-center randomized trial on using steroid for people who've got early stage pleural effusions. But unfortunately, steroid didn't make any difference. It did in a pediatric parapneumonic effusion study, but not in our adult parapneumonic effusion study. Early recognition is always important, and early recognition and drainage is always the key. We work with the group in Utah, and we published a paper in Chest a few years ago now. If a patient presents with pneumonia to the emergency department and there's evidence of pleural effusion on that chest X-ray, if you ignore it, even in America, there's a 75% chance the patient will come back to hospital and needs to be admitted. And they then need to stay longer and have more chance to require surgery. So I think absolutely your point, early recognition, early treatment, so-called the sun should never set on the parapneumonic effusion still holds true.
So I agree with your point that we shouldn't treat the X-ray, we should rather target the sepsis. So one of my question is that sometimes on follow-up that we see the X-ray is not resolving, and when we perform CT, there is significant volume of effusion. Even then, the septic markers are low. What we should do at that point?
Yeah, so I think that is not uncommon if the patient has a thick rind of the lung, of the visceral pleura because of the infection. And so they basically have a trapped lung space. And so in those kind of patients, it is difficult. Our job usually in those situations is to make sure, because the fluid will come back and fill up that gap. So you're always going to have fluid in that trapped lung space. So in the acute phase, our job is to try to make sure the patient is adequately treated on enough antibiotics so that when the fluids comes back, is not infected again. Because as we've shown, there's a lot of bacteria on the pleural tissue. So when the fluid comes back, we want to make sure that the fluid is not secondary infected again. So I do tend to keep those patients on slightly longer courses of antibiotics and then gradually withdraw and make sure that the fluid is still sterile. If the fluid is sterile and the patient is well, then we'll just leave the fluid to be. And over time, that trapped lung thickening in most patients, not all, but most patients will get better.
Whether the surgery on those patients improve the lung functions and especially in young patients, whether that improves their lung functions and whether it will have any long-term future benefits?
Yeah, so that depends on what the risk and the benefits will be. And I think having a discussion a little bit down the track, not in the first few weeks. The surgeons will say that the best time for decortication is 6 to 8 weeks' time or something like that. But you do need to know that decortication has got a significant risk of persistent air leak. So it's usually in the range of at least about 20 to 30%. So what you'd think about is that you know, for most pulmonologists, we just write a referral and send it to the surgeons and think that everything will be magically performed to perfection. If you go and refer a patient to surgery, please go and watch the surgery, because I watch a lot of surgery. Every time my patient has to go to surgery, I try my best to actually go and watch. So in those situations, the lung, imagine the lung like a balloon, and you got layers of paper pasted on the surface of the balloon, and you're asking the surgeons to peel the paper off without puncturing holes in the balloon. It is very hard. And in some cases, when it's matured, there is a plane separating the lung and the pleural thickening, and you can do that. But the harder you try, the more likely you make multiple holes. And a lot of these patients then end up staying in hospital for a very long time with persistent air leak, and you regret having ever sent the patient who was well to end up in hospital with persistent air leak. So it's a very fine balance. And there has been some papers that has been done about lung function, and all of them have shown no improvement on the lung function before and after decortication, which means that 50% of people probably improved and 50% got worse, so the average has no change. So the difficulty is your patient going to be the one who sailed through surgery with no complication and has improvement, or is your patient going to be the one who's end up stuck with a chest drain and bubbling for another 3 weeks or 6 weeks? That is the difficulty.
Yeah, so I'm afraid we have to close the session now. And on behalf of the Sri Lanka College of Pulmonologists, We are deeply grateful to you for your presence here today. Thank you so much.
Please remain on stage, sir. Thank you very much for that insightful lecture. And now, to present the token of appreciation to the speaker, Professor Giri Lee, I cordially invite the chairpersons, Dr. Ravini Karunatilaka and Dr. Niranjan Dissanayaka. And next, I invite the President of SLCP, Dr. Bodhika Samarasekara, to present the tokens of appreciation to the chairpersons. Thank you very much, sir. And now we will begin the symposia for the day. Symposium 7 will take place in these premises, while Symposium 8 will take place in Hall B simultaneously. Please bear with us a few minutes until we partition the hall. Thank you.